Thanks. And I think this discussion leads in perfectly into our next topic. And it's my great pleasure to introduce our next speaker, Dr. Ken Chang, who has been with us all this morning and sharing his experience with us. Dr. Chang is a professor of medicine and chief of gastroenterology and hepatology at UC Irvine. And he's going to be talking to us about endoluminal fundoplication here to stay. And I put a question mark after that. So I guess, Dr. Chang, you can tell us whether it's going to be a period or a question mark after that here to stay.
Hey, thank you so much to be here. Let's see. Can you let me see. Are you seeing anything from my share screen?
Yes, we are. We are seeing your first slide.
Okay, perfect. So thank you so much, Mihir, for inviting me back. I've really enjoyed your course, and especially when it was live. But I want to thank you and Paul for organizing this, Steve, Hazem, Shelby, all you guys are good friends for a long, long time. So it's my privilege to talk about endoluminal plication, here to stay. My short answer is yes. But let me go over some key principles that I think would be helpful. These are my disclosures. So there are a lot of endoscopic anti-reflux procedures that have come, and most of them have gone over the last 30 years. That's you and I, Steve, 30 years. But there are finally things that are going mainstream, and I want to talk about why I think they're here to stay and what the principles are that we've not been able to achieve, but now we finally are able to achieve. So I'm going to continue to harp on the anatomy and the physiology, because that's ultimately our goal, is to reconstruct the anatomy and physiology of the optimal anti-reflux barrier. So currently available are the Stretta procedure, TIF procedure. ARMS is really taking some enthusiasm now. But I'm not going to talk about all of these. Time doesn't permit. I'm going to talk about the goal of restoring the anatomy and physiology, and focus on the TIF procedure, because I think of all the procedures, this is the most covers the most of those guiding principles in terms of restoring anatomy and physiology. We know GERD is on a spectrum, and certainly on the right-hand spectrum, we don't want to attempt endoscopic anti-reflux by itself, but we do have opportunities for endoscopic anti-reflux on the left, and then a combination of endoscopic and laparoscopic on the right. So we appreciate that there's several mechanisms to prevent reflux into the esophagus from the stomach. And I talked to my patients about the two valves, the inside valve and the outside valve, the inside valve being the lower esophageal sphincter, which includes those sling fibers which go into the stomach. And the outside valve is obviously the diaphragmatic crura, which is equally important. And one of the things that we're realizing is if you fix the inside valve, but the outside valve is loose, that's not good. If you fix the outside valve and the inside valve is not fixed, that's not good. And you actually have to fix them more or less simultaneously. And the analogy I like to use is the door and the door jamb, the door frame. So the door is your inside LES, and if the door is broken and you fix the valve, but your door frame is warped and loose, then the door won't work properly, and the same the other way around. The two work together synergistically, and we have to think about them also simultaneously. So the lower esophageal sphincter has been studied much more carefully in the last decade. And now endoscopically, we're beginning to think about and focus on the gastric sling fibers, which are part of the physiologic flap valve. So if you look at this endoscopic picture, that little ridge there, that's a normal sling fiber that encompasses the flap valve and encircles the G junction with attachments towards that lesser curve. So it's a real anatomic structure and with a real physiologic role as an anti-reflux. And it's this valve that is important to consider when we do POEM. If we cut right across posteriorly here or anteriorly here, and we just cut right across, we are doing ourselves a disservice on the GERD side. But if we land here on the lesser curve, then we're least likely to have GERD while optimizing the relief of dysphagia. The other thing I want to point out is for surgeons who do sleeve gastrectomy, by definition, a proper sleeve gastrectomy will cut through the sling fibers in the cardia. So by definition, a laparoscopic gastrectomy kills your anti-reflux mechanism. Just a food for thought. Okay, so then those are the sling fibers superimposed, and if I flip it around, it'll look the same as that diagram. And again, the flat valve will close from greater curve to lesser curve. That's how the muscular framework is designed. When these muscles contract, it'll close the door from greater curve to lesser curve. And that's the same here, from greater curve to lesser curve. So our goal with any anti-reflux flat valve reconstruction is to essentially mimic this and reconstruct this similar mechanism. So we talk about the Cura and the LES, and perhaps kind of related to the LES, but maybe think of it separately, is this GE junction flat valve, which is a muscular mucosal anatomic structure which is meant to close as a one-way valve, that food and fluid will come down nicely, but anything trying to go back up will close the flat valve. And this has been shown even in cadavers. This will happen. This flat valve will work even in a cadaver model. So where else in the body do we have this flat valve mechanism? Well, we don't have to go too far. The vesicular ureteral junction. Why is it that urine in the bladder doesn't reflux back into the kidneys? And that's because of this junction, which is the other flat valve in the body that we don't really think about. And the flat valve works because it has length, and it also has an angle of approach that is oblique, not perpendicular. So here in letter A is a nice long tunnel with a adequate flat valve. B, medium tunnel with possible reflux, and then C, a very short flat valve with a perpendicular approach, and that's a high risk for reflux. So similarly with our G junction flat valve, if it's short and the angle of approach is flat, the patient will likely reflux. So on the left is a flat valve that's been disrupted over time in a GERD patient. In the right is the restoration or putting things back the way they used to be, with a nice long length of the valve. But as important as the length is, and as important as the diameter is, the floppiness of this flat valve, so that fluid and food trying to get back up will more likely close the valve as opposed to go up. But it has to be loose enough so that air can still pass up by way of venting from the stomach. So the flat valve factors influencing flow back into the esophagus includes the diameter, the intra-abdominal length, and also the medial to lateral movement of the flap, as well as the orientation of the movement from the greater curve to the lesser curve. And doing TIF procedure, I feel that we've approximated as much as we can some of these anatomic physiologic guiding principles, creating length, creating smaller diameter, but floppiness that doesn't have a lot of fundus wrapped around stomach. It's such it's an umbrication and elongation of the natural flat valve, and to create the floppiness from that greater curve to the lesser curve. So here's an example of a pre-TIF procedure where the sling fibers are short, the angle of His is quite shallow, and this is loose. And after the TIF procedure, you can see the valve length is very long, but the diameter, although smaller, is not a stricture. It's not super tight. And we're not using a lot of fundus to create the valve. We're just pulling down the G junction, creating that flat valve, which moves from greater curve to lesser curve. So here again is normal. This is the normal patient, no GERD. They have a normal GE flat valve. This is a patient with GERD who has a Hill-2 GE flat valve where the sling fibers are loose. They don't have a hiatal hernia, but the gastric sling fibers are loose. And this flat valve is shortened and more flat, and the angle of approach is also more perpendicular. And here again is after the TIF procedure where the valve is lengthened and it's restored to its proper anatomic and physiologic orientation. So the flat valve again is going from greater curve to lesser curve. And so here also greater curve to lesser curve. And then, of course, the diaphragm, the door jamb or the door frame needs to be also considered. And we've learned that the right cruce envelops the G junction and pulls on the G junction to the right and posterior and inferior. And if we look at the physiologic studies, this is a normal patient. This is a barostat balloon that's radiopaque and placed across the G junction. And this right angle turn at the almost like the tip of a hockey stick is created by the right cruce. And so that is an important anti-reflux barrier. In a patient without a hiatal hernia, but a Hill grade 3, that angle is now more straight. And that's because the Hill 3 anatomy allows looseness at the hiatus. And so this tightening of the G junction by pulling to the right, posterior, and inferiorly is compromised because the muscle can no longer envelop the G junction the way it used to. And then, of course, you have the hiatal hernia situation, which we're all familiar with. So again, this coordination or synchrony between the two is important to keep in mind. This is my computer cable acting as the right cruce around my plastic stomach. And the direction of that is to the right and posterior and inferior. This is the flat valve that I've created with TIF, and I'm going to flip that around and I'm going to push it over here. And what is the direction of the flat valve in its proper location? It's exactly the same from greater curve to the lesser curve. And no surprise, the way that we're created is that that cruce and that flat valve move in the same direction. It would be kind of interesting if they were moving in opposite directions, but they work in synchrony. So we want to consider both the door and the door frame when we think about GERD. So the TIF device we're all familiar with, and the procedure, I'll just quickly, for those of you who may not be familiar, it's an endoscopically guided procedure. The device is placed at the G junction. There's a helical retractor that grabs the G junction, pulls down and creates the valve length. And then these two H-shaped polypropylene fasteners are placed to keep that valve structure intact. And then it's a matter of going around the G junction of 270 to 300 degrees, creating a valve that's 3 to 4 centimeters in length. And then there's healing that occurs with fibroelastic tissue that keeps this valve structure robust for many years. We've had patients out almost 10 years and the valve still looks the same. And so these are the fasteners seen creating that flat valve that we talked about. So there's a lot of level 1 evidence now that 72 to 80% of patients can come off their PPI and eliminate troublesome regurgitation. And these were well done randomized controlled trials, which is summarized here. And today we're seeing a rapid expanding indication for TIF procedures. We're applying this to the general GERD population for those with a Hill 1-2. We're now looking at Barrett's post-ablation, post-EMR who've reached CRIM and looking at to see if TIF can get them off their PPIs. That's in a lot of our clinical trials now, as well as the TIF registry. I think that post-POEM GERD TIF is a great indication because we are the one who disrupted the flap valve. And if they don't have a hiatal hernia, then for us to recreate the flap valve is ideal. And these patients respond very, very well. And there's no issue with increasing dysphagia because of the way that the TIF valve is constructed. We do TIF now before or during endoscopic sleeve as needed, or even after endoscopic sleeve, as long as the TIF device can retroflex. We're looking at laparoscopic sleeve gastrectomy. We have a clinical trial now looking at doing it before sleeve gastrectomy. Post-sleeve gastrectomy, more difficult if the sleeve lumen is narrow. In patients with no peristalsis or little peristalsis, such as scleroderma, we find that the TIF procedure minimizes the issue of dysphagia after an anti-reflux procedure. And we feel that younger patients, meaning patients in their 30s and 40s and even 50s, if we're looking at a redo sometime in the next decade or two, if we do a TIF or C-TIF, we wind up having easier time on the redo because of not having to take things down in order to tighten. We just go in and tighten. Prior fundoplication that's gotten loose, that's one really good indication for TIF. And in the last 5 minutes, I wanted to show you a how I do it video because that's what this course is about. So this is the valve that I strive to construct. It's an omega-shaped valve. On the greater curve is where I try to get the most length. I typically get 3 to 4 centimeters of length on the greater curve. But trying to recreate that flat valve, I don't necessarily want 3 or 4 centimeters on the lesser curve. I wanted to kind of get shallow and shallower as I get tighter and tighter into the corners. So right here on the posterior corner, the valve lip is shallow. On the greater curve, it's quite long and steep. And then on the other anterior corner, it's also more shallow. So it's a horseshoe omega shape in terms of the fastener pattern. So on the right, you'll see this is the pre-procedure valve that's loose that I showed you earlier. And I'll show you the TIF procedure and then what it looked like afterwards. So the other thing is we've modified the TIF procedure a little bit. And what we're doing now is this is called mid valves. So after completing the valve, I like to put 3 or 4 fasteners in the mid section of the valve. That helps to create additional anchoring adhesion points of adhesion. These are my reinforcing sutures, so to speak. And we find over time that the valve even stays longer and the valve looks really nice when we follow them up months later. So I'm doing these mid valves now routinely. So for the procedure, this is the TIF device going in, and I'm rotating to that posterior corner and putting my helix and try to anchor right near those sling fibers because I can really get a good strong hold right at the G junction near the tip of the sling fibers. And then I'm rotating out, and then I'm setting my device by just pulling it back so that it's at the proper distance within the esophagus. And from here, I'm going to create the valve length by tugging on the helix and pulling that G junction down into the depths of the tissue mold. So here it is, I'm pulling. And by pulling maximally like this, I am 3 to 4 centimeters deep with the valve. And then in the corners, I need to create length as well as create the wrap. So here I'm wrapping along the posterior side, moving clockwise towards that lesser curve. So I rotate the device towards the lesser curve, and then I will apply suction to stabilize and then fire the fasteners. So here you see on the right, this is the first fastener that I've placed. This is around 10 o'clock. It's the tallest of the 3 plications on the posterior corner. My next 2 will be more shallow, but each one will be further wrapped deeper or with more rotation. So the second, so here I'm going in for the second plication. I'm rotating, I'm plicating, I'm coming back out, and that's my second plication. And then I'm reloading, I'm rotating, and that's my third plication. So 3 plications in a row, but taller, shorter, shorter, but going more and more aggressively into the corner. So after 3 plications on the posterior corner, I go to the anterior corner. Here I'm anchoring at around 12 o'clock, right at the Z line. My anchor is well secured. I roll out, I set the device, and then here I'm pulling down, creating the valve length, and then I'm rotating. Now I'm rotating in the opposite direction. I'm rotating counterclockwise to wrap stomach around esophagus, just like in a fundoplication, but I'm using very little fundus. So you can see the nice length. This is 4 centimeters of length that I'm creating here. So I'm going to put the first plication in, and there is the fastener, the first fastener on the anterior corner. And then I'm going to reload, and I'm going to go in a second time, rotate a little bit further, and put the second fasteners in. Each time I plicate, the 2 fasteners will go out simultaneously. And then the third plication, I'm going to go more shallow. Sometimes I push the device even further into the stomach to get more shallow, and then that'll create the third on the anterior. So that's 6 plications. Then I go to the greater curve. I anchor around 6 o'clock, grab tissue there, and then set the device. And then I'm going to close and I'm going to fire. So there's my fastener high, very high at the 5 o'clock position. I'm going to do a second one at 6 o'clock, a third one at 7 o'clock, and then finally one more at 8 o'clock. So here, 4 fasteners high up to create the longest flap valve possible. So when I finish this is the 10 plications, which is just the standard set. But then I go above and beyond this. I look for opportunities where it might be a little bit loose. And typically I'll go to that if you look at this posterior corner, I think I have room to make it a little bit more snug. So what I like to do here is I go to that posterior corner, and here I'm not going to use the helix. I'm just going to use the device and kind of fold it into that crevice, deflate the stomach, and then rotate significantly, and then do another plication posteriorly. And if you can see now, I've done 2 posterior reinforcement. And if you look at that corner, it's tight now. It's come in quite a bit. I'm going on the anterior side. I'm going to do 1 reinforcing plication on the anterior side. And now I'm happy with that, with both corners. And now I'm going to finish with just 3 mid valves. 1 here at 8, boom. 1 here at 6, boom. 1 here at 4, boom. And we're done. This unedited video is 30 minutes, so it didn't take me a long time. And we come out. And as we're coming out, I use the window of the device to look at my suture pattern, fastener pattern, and I can see a very nice omega-shaped valve. It's about 4 centimeters long, about 320 degrees, with the lesser curve spared, as the guiding principles show us. And then here on endoscopy, you can see we're looking from the crura indentation. Everything below the crura now, that's all valve. So that's 4 centimeters of valve. Now I'm going to go through the valve, and then I'm going to retroflex, clean up a little bit, and this is the final fundoplication, keeping all of the anatomic physiologic guiding principles in mind. So with that, I'll stop and join the group discussion. Thank you.
Thank you, Ken. That was wonderful. I think, just explaining the anatomy, I think as gastroenterologists, we probably don't understand the anatomy at the hiatus and GE junction at all, I should say. I know we know something about it, but not in the depth that we need to know when we get into the GERD space. So thank you for sharing with us all of that, and the procedure itself. I know the procedures evolved. Different people are adding more, of their experience to doing these, placing more fasteners in different locations. So thank you for sharing that. So right now, I'm not seeing any questions from our audience. So if
I
there's
do.
someone who has
I do
any
have a
questions,
question actually.
yes, go ahead, Mohammed.
Yeah. So actually, my question is related to doing TEF postpone because we start doing it postpone, and we noticed I don't do them. My partner, and by the way, I learned a lot, Dr. Chang, and you made me now a strong believer. I'm gonna send more of my patients for this procedure from now on because I was doubtful till I saw what you are doing, which is beautiful. We noticed there is fibrosis at the GA junction, which make maybe TEF not as ideal in patient postpone. Do you have experience doing it in these patient postpone?
Yeah, we've done quite a bit of TIF postpone, and it's interesting. The achalasia subtype actually predicts which patients are more likely to wind up with a TIF than not. The least likely to get a TIF, I think our study showed 1.6% of type 2s will need anything. I mean, will need a TIF. No one needs surgery. 50% need PPI, and about 1.6% will get a TIF. But the spastic disorders, the jackhammers, are more likely to wind up getting a TIF. So I'm not sure why that is, but probably there's an explanation. I find that TIF in postpone patients is ideal because a lot of these folks, their esophaguses are dilated, there's redundancy, and so you can pull down on it and get a very nice length. And most of these folks don't have an open diaphragmatic hiatus. They don't have a hiatal hernia. It can happen, but that's not common. And so you've got an almost artificial kind of situation where clearly it's just the flat valve that needs to be reconstructed because we tore it apart, right, with our POEM procedure. So then if you do it, months after the POEM, sure, there could be scarring, but you're just creating an umbrication and you're fastening it. So you don't have to worry that the tissue planes are, not all, pristine. So no issues that I'm aware of with that. There are some people looking at simultaneous TIF, like immediately on the same procedure. They do a POEM and then do the TIF, and that's the analogy of the Heller myotomy and fundoplication. And the argument for that is, well, if there's a high chance for GERD, why not just do it on the same procedure? The counter argument is, well, the vast majority don't need anything other than PPI, so why are you doing this on everybody? And I'm of that school. I've done maybe 2 simultaneous, and that's in a sigmoid esophagus type 1, where I'm almost positive that they're going to get GERD, and their dysphagia may not respond to just the POEM alone, and then I may offer them a simultaneous TIF. But again, I've only done 2 cases.
My second question is related to the sleeve. You mentioned you do it before the surgery because after surgery you don't have a space. Do you only do it for patients who have reflux before surgery, or for all newcomer for sleeve, you just do TIF on them before surgery?
Yeah. So right now our clinical trial is looking at patients with pre-existing GERD, whose BMI makes them candidates for a traditional sleeve. But no one will do a sleeve on them because of the GERD, and they absolutely don't want a gastric bypass. So we're doing actually CTIF, and then after 3 or 4 months, we're doing the sleeve. And we feel that staged approach may make a lot of sense. We're not doing this routinely. At some point, we'll be able to sort out and hopefully predict who will more likely get de novo GERD. But the startling fact, as I mentioned, is my Ninh Nguyen, who's past president of ASMBS, said to me flat out, Ken, I just realized that with every sleeve that I do, I am jacking the G flap valve. I am just cutting right through it. And so it's a wonder why not everybody after a sleeve gets GERD. And so now the surgical world is starting to wake up to this, and either they need to do an anti-reflux first, or they need to modify their sleeve so they don't cut through the G flap valve.
So I'll just say that we have looked into, pre-sleeve doing a TIF, and the one thing that we found is we were still exploring. So I did the TIF, and a week later, the surgeon went in to do the sleeve. And that was not a good idea. There was a lot of inflammation, edema, and they had a tough time doing the sleeve. So now we've kind of changed our approach. Again, we don't do it for all patients, but those with pre-existing GERD. And we have now decided we would either do it at the same time intraoperatively, or we would stagger it by 3 months or so to let the TIF heal and then do the sleeve. So if at all someone's looking into it, this was just a way we learned what we should not have done when we started. So I think there's one quick question we can take, and we're running a little behind, so we'll move on to the next session. The question that we have from one of our attendees is, are there any special considerations for TIF in patients with Barrett's esophagus?
Yeah, so I think the consideration is it's quite doable. Even in patients who've gone through multiple EMR and ablations, we haven't found that the TIF is more difficult unless they have a stricture. Then the device may have difficulty getting through. So from a technical point of view, TIF is doable, but the main thing is it appropriate to do TIF alone in someone who's had Barrett's? Because the Barrett's patient has had long-standing GERD, severe GERD, and the chance of them having a normal hiatus, normal crura, and it's just the flap valve that needs the repair is probably unlikely. So I've changed my thinking about this, and I think that post Barrett's ablation patients should probably get a C-TIF and not a TIF alone. That I don't have data. That's just my hunch.
All right, very good. Thank you so much. I think that's all we have time for questions at this time. So I think we'll move on. Thank you, Ken, for sharing with us. And now our next session is our ESD and POEM bag of tools. So I would encourage all our faculty to join in, turn on their videos if they're available, and we can. This is going to be just a group discussion. This is a kind of an experiment that we decided to do at API this year. There's no script other than two of our fellows, our GI fellows, will be presenting some devices and basically showing what devices are out there for ESD knives and for closure. And then we'll just get a panel discussion going as to what people like about these different devices, which they use, when they use it, and so on. So I'm delighted to have our faculty join us. Dr. Aihara, thank you for joining us. I know you had a conflict earlier on today, but your talk was wonderful, and a lot of people were referencing your work in their talks as well. So thank you for joining us.